you gotta work with patients, probably engage with them a lot more closely, and make sure that this doesn't come off as a threatening response, that you're worried about them, not that you're mad at them. So point being, you need to have an open discussion with patients about difficulty with ending use. You want to talk with them openly. You want to warn them that this isn't going to be easy, and that if they have any problems, they need to come talk to you, and that if they're struggling with, if they feel like they need the opiates and we don't, we've agreed that that's not a good thing, that they should come back to you rather than go to somebody else seeking the opiates. Offer them treatment, get them help in substance use treatment, get them engaged with addiction providers, and continue regular follow-up after discontinuation. So once they've stopped, don't assume that they're not using anymore. Talk to them about their pain management. Make sure that they're not getting opiates from somewhere else, be it heroin on the street or somewhere else. You gotta don't assume that just because you're done with them, they're done with them. So anyway, patients are at really, really high risk during and after discontinuation. So both risk of unmanaged pain and disability, self-harm, suicidality, drug seeking, overdose with their previous dose. So again, people, they're tapering. They may decide this isn't working. I'm just gonna go back to my regular dose, and then they're gone. And so what you need to do is monitor them frequently, assess their withdrawal symptoms, pain, mood, sleep, suicidality, drug and alcohol use. And you have to treat symptoms, as we talked about. I think one of the things that I would recommend is again, you're not going to be able to assess people as frequently as you need to with ongoing in-person primary care visits, except it's some miracle healthcare system that I haven't studied. So finding ways, of doing phone monitoring or other check-ins. I know people are starting to develop really great internet tools where you can have patients self-report how they're doing over time. You gotta stay in touch with them more frequently than what your visits are likely to allow. So doesn't have to be long, just brief check-ins, make sure people are doing okay. Also even if you don't think they'll turn to heroin, chances are they have friends and family and all sorts of other people who will hand them drugs if they think that they're hurting, and they may have been well trained to do that. So, be careful. Okay, so before starting and periodically during continuation of opiate therapy, clinicians should evaluate risk factors, and they should incorporate into their management plan strategies to mitigate risk, including considering offering naloxone for people who have high risk of overdose, such as history of overdose, history of substance use, or higher opiate doses, or concurrent benzodiazepine use. So they recommend a few risk factors that they think you should look for. This is, I think, fairly impressive because, again, the first time naloxone's been recommended as a clinical protocol within standard medical care. So it's a key part of this says you need to look for risk. I've given you guys a sense of what things are. There are much more structured ways of assessing risk, which are much more comprehensive. So there are 3 risk assessment tools that I would recommend, the ones that are most validated. One is called the Screener and Opiate Assessment for Patients with Pain. This is a paper and pencil screener. It's available online, which has been developed to predict risk of opiate abuse. It takes a little bit of time to do, but it's not that hard, and it gives you a risk score with recommendations of how much to worry about a given patient, and I'll show you that in just a second. There's also the Risk Index for Serious Opiate-Induced Respiratory Depression or Overdose, REASORD, which is a model to predict respiratory depression overdose events. And there's both a paper and pencil version, and it was based on medical record samples, so you can, in fact, calculate it based off of existing data in a medical record, if you got somebody who's creative with electronic medical records. And then the stratification tool for opiate risk management, or STORM, it's a electronic medical record based model to predict overdose or suicide related events. That one is currently available to all VA clinicians now, but not currently available to other people, except if you want to do a lot of math. So I'll show you STORM really quick. This tool data mines the electronic medical record, pulls out all predictors for patients with opiate risk, shows and provides information on all patients with an opiate use disorder diagnosis or an active opiate prescription. Uses a prior model to estimate risk in terms of likelihood of an overdose or suicide event, and helps then recommends risk mitigation and tracks use of risk mitigation strategies for those patients. So this just gives you an example of what this electronic medical record-based report looks like. So you get basic patient detail. The model gives you the percent risk. So this patient shown here has a 60% risk of a suicide attempt or overdose in the next year, based on the risk factors listed there. So relevant. So your substance use diagnoses, mental health, medical, and adverse event risks, and medications that they're currently on, which are categorized into opiates, sedatives, and pain meds. It then helps provide a tailored list of risk mitigation strategies that you might consider with a patient based on their active diagnoses. So for example, since this patient has an opiate use disorder, it recommends opiate agonist treatment, effective treatment for opiate use disorders. Since the patient has a sedative, it recommends tapering the sedative, also recommends minimizing doses, naloxone kits, et cetera, and tracks whether or not you're using those in practice. So I recommend, you don't necessarily have to have an electronic medical record-based tool, but both the concept of this is exactly what the guideline is recommending. You need to sit down, think about risk, consider what your risk level is, consider your options for risk mitigation, and then apply them as needed and repeatedly as needed, right? So for example, you got a urine drug screen frequently, you got to repeat, re-prescribe your naloxone kit when it's gone. So SOAP is a 5-minute paper and pencil screener. I'm not going to go through it, but it basically has similar medical risk factors, patient prescription information, dose level, and things like emergency room visits. So they're all conceptually similar, and Reazor does same sort of thing, similar set of questions with slightly different outcome. Main goal here is what you want to do is match your risk to your treatment regimen. So you need to use your risk level to set your dosing guidelines, but also set your monitoring protocols. So if you have a high-risk patient, you need to have more frequent follow-up visits. You need to increase participation of specialists. So don't try to do it. You got a really high-risk, complicated patient. Don't try to do it on your own. Bring in your pain specialist, your mental health, your addiction specialist if that's appropriate. Bring in clinical pharmacy to help when the patient has a list of meds this long. Bring in physical therapy, rehabilitation, social work to help people get engaged in activities, help them get, find a gym or exercise program or something like that. So you bring in people to help when these are complex patients. And make sure you're addressing risk factors. So you've got to identify them, which includes, urine drug screen, to find out if they're using substances they're not telling you about, assess for sleep problems, and get them treatment insofar as you find risk factors that are treatable. Okay, next recommendation. So patient should review the patient's history of controlled substance prescriptions using state prescription drug monitoring program data to determine whether the patient's receiving opiate dosages or dangerous combinations that put them at risk of overdose. And you should check your PDMP before you start and then every 3 months after. So I don't know how many people have ever looked at a prescription drug monitoring data? So there are now 47 states now have prescription drug monitoring programs, which is good. The one downside of them is they're all pretty much independent. It's not completely true, but it's mostly 47 separate systems. And they generally require registration, so you need to sign into them. chances are you're not going to do that 47 times. So I think the assumption is that you're going to check your state's prescription drug monitoring program, which of course isn't going to pick up everything because patients could have gone out of state, especially if you live on a border. It is a HIPAA disclosure. So if you're querying the PDMP, you have to track that because it is a HIPAA regulated disclosure, and you have to document that as well. But what it'll give you back is information about all the other controlled substance prescriptions that the patient has. So you can get their full history of controlled substance use. So useful information. It is a bit of work to get at it. This is not like a press the button, presto, it's right there. So you're going to have to put some effort into it, but it is a useful, important thing to do, and people are constantly surprised about what they find. I will say people who've made this a regular practice, the main thing I hear from them is that they don't get back what they expect, that there are people who they think are just fine who often aren't, and vice versa. So don't assume that you're really, really good at finding the people who are substance using, because almost no one isn't. One of my favorites was we had really, really amazing pain specialist who was working with most of my young research assistants, and he basically said, well, I only urine drug screen the people with tattoos because I assume that they're the substance users. And we were just like, are you kidding me? Like, that is such a bad marker. And like, anyway, so point being, everyone has their little mental way of thinking that they know how to find who's substance using, and they're all wrong. So just screen, check. Okay, so when prescribing opiates for chronic pain, clinicians should use urine drug testing and consider urine drug testing at least annually to control for prescribed medications. Also, you got to check for substance use to make sure that they're taking what you're prescribing. We talked about this as a bit, so I'm not going to spend much time. I also emphasize do your normal drug screens, add in anything that is commonly misused. Check what your standard drug screen is in the lab, and make sure that it's screening for things that you actually think are there. Lots of drug screens don't include fentanyl, for example. Not a good thing. There's a whole bunch of missings in many drug screening protocols. So check, make sure you're going to get back what you need. And also, typically opiate screens just look for morphine, right? So if you're prescribing anything other than morphine, you may need to do additional drug screens to make sure that you're getting the other drugs that the patient may be using. And then also make sure you're screening for alcohol and tobacco use. I think people think of the urine. You're not going to do that by urine, but you got to ask too. And that should be part of it. It's just sort of neglected in general. And the thing I would say here is make sure you're framing this as a safety check for patient risk, not I'm checking to make sure you're not lying to me, which is how patients tend to take it. I think the way you could say is, I know you don't know necessarily all the things that you're ingesting. There are lots of things that could interact. I need to check to make sure that I can prescribe safe to you, not I think you might be using drugs and I'm going to check because I don't know if I'm going to give you these opiates otherwise. Like that doesn't make people like you very much, nor does it help them come back. So lastly, this is not quite last, but clinicians should not avoid prescribing pain meds with benzodiazepines. Here, the way you should handle this, so if you have a patient, and there are many, many patients on opiates and benzos, you want to handle the benzos just like you're handling the opiates, right? So if you don't have evidence that those benzos are effective and they are putting patients at risk, and benzos increase risk of falls and other accidents as well in fairly substantial ways, and especially when mixed with opiates. So especially, when you get older people who may have been on opiates for years and years and years, and now in benzos for years and years and years, and now they're getting older, the risk may just go up because of their increasing age, and you may just need to take them off. So taper your benzodiazepines, same strategy as with opiates. Nice and slow over time, manage side effects as needed. With benzos, you want lots of psychological support, regular assessment. People are going to have trouble with anxiety and insomnia. You need to help them. One thing I'll emphasize, I don't know if a lot of people are aware of it, but cognitive behavioral therapy for insomnia is very, very effective, much more effective than benzodiazepines for sleep management and insomnia. Very rarely used. So, if you can find a place to send patients, that can be very, very helpful as you help people off. And there's a guide here if you want about helping patients taper off of benzodiazepines if that's an appropriate option. Recommendation 12 is that clinicians should offer or arrange evidence-based treatment, usually medication-assisted treatment with buprenorphine or methadone in combination with behavioral therapies for patients with opiate use disorder. Thing I would emphasize here, untreated opiate use disorder has an extremely high mortality rate, up to like a 10% risk of death per year. So in samples we've looked at, 13% of patients with an diagnosed opiate use disorder died in a year. It's incredibly high risk. But that being said, we have some of the most effective treatments of any mental health disorder for opiate use disorder. So medication-assisted treatment with methadone or buprenorphine done in accordance with guidelines for that treatment. Studies have shown up greater than 75% effectiveness after a year of therapy in guideline concordant methadone clinics. So what that means is that of everybody who walks in the door of a methadone clinic, 75% of them will be opiate abstinent a year later. So really, really effective, good long-term outcomes if you can get people started. Okay, we're running out of time, so I'm going to go through this quicker. So there are very effective treatments of opiate use disorder, medication-assisted treatment. We're going to talk about exactly what that means in a minute, but it should always be done in conjunction with adjunctive psychotherapy, psychosocial services, and monitoring, right? So this is not a give them the medication and their addiction goes away. This is give them the medication and they're in a good place to start doing recovery-oriented activities and changing their behavior. Also, one thing that's been found to be very useful to pair with it is contingency management, and I'll talk a little bit more about what that is. Essentially, what you're doing there is providing rewards for things that aren't rewarding, like drug abstinence or getting through withdrawal symptoms. So you're going to actually come in and give people, oftentimes, essentially like lottery tickets for gifts or even pay people. And it works very, very effectively. And you can actually do it with the incentives don't have to be big to change people's behavior in huge ways. So I'll talk about that in just a second. But that can be particularly helpful if you have somebody who's not just abusing opiates, but are taking a bunch of other things on the side. So the opiates plus the sedatives, and maybe they throw in a bit of alcohol on top of it. The medication-assisted treatment will specifically work for the opiate part of the addiction. It won't touch the rest. So oftentimes you get people stop the opiate use, but they continue all the other substance use. And so contingency management can be a good way of addressing that, as well as the other psychotherapy. Okay, so a couple different types of medication-assisted treatment. Most effective and well-tested type is opiate agonist treatment. Concept here is you're going to give patients very high doses of a long-acting, slowly absorbed opiate. So you're going to give them really high dose, and you're going to make it really, really stable, right? So it's not bumping up and down. It's not causing any learning in your reward circuits. And it's filling up all of your opiate receptors, right? So all your opiate receptors are sucked up, taken off. There's nothing left for any other opiate to interact with.